All right. Hey, everyone. We're just going to give it a minute for a few more people to filter in. It's only 3 o'clock so far. Okay. We can go ahead and get started if that's all right. I know we have a few lab meetings that are also ending right around now, and people are trickling in, but I think we can go ahead and get started. It looks like we're also recording, so we should be in good shape. Well, hello, everyone, and welcome to the October installment of our CFAR-Wide seminar series for the Tennessee Center for AIDS Research. I'm John Curta, the director of the CFAR, and today we have a very special guest who we're excited to welcome, Dr. Cedric Pulliam, who will be presenting Empowering Change, the Role of Collaboration in Combating HIV Policy Challenges. And for the introduction, I'm actually going to step back and turn it over right now to Christian Amador from the Meharry School of Global Health. And I think, as many of you know, Christian is co-lead for our new health policy and HIV scientific working group. And in some ways, this is our seminar that we're very excited to launch that working group. So Christian, take it away.
Yeah, thanks, John. Echoing your sentiments about being very excited about this. And it is my privilege to introduce to all of you Dr. Cedric Pulliam. He's a visionary leader and public servant whose work has shaped global and national approaches to HIV, health equity, and human rights. Dr. Pulliam brings over 13 years of experience serving in the U.S. federal government, where he has advanced efforts in global health, including HIV/AIDS, tuberculosis, and malaria, as well as LGBTQ+ and human rights policy, public policy, health equity, foreign affairs, and international development. His career reflects a steadfast commitment to leveraging policy as a tool for justice and inclusion. Dr. Pulliam holds 2 master's degrees and a dual bachelor's degree in international relations, political science, regional and conflict studies, international development, security policy studies, and criminal justice. He later earned his PhD in health and medical psychology, where his research explored the psychosocial and sexual effects of using pre-exposure and post-exposure prophylaxis among young men who have sex with men of color ages 16 to 24. Today, Dr. Pulliam contributes to this evolving dialogue through his presentation. Please join me in giving a warm Tennessee CFAR welcome to Dr. Cedric Pulliam. And just before I hand it over to him, I just want to make a little housekeeping note that we will be taking questions throughout the presentation. Dr. Pulliam is happy to answer your questions, so we'll be monitoring that. Dr. Pulliam, floor is yours.
Thank you so much, John and Christian, and thank you all for joining today. It is my distinct pleasure to be with you to present this work, and it's exciting just because this is something that excites me every single day to be able to showcase and to get people energized and invigorated to do the great work that is needed around the never ending policy challenges that we are seeing happening within HIV and public health fields. I'm just going to get my slides together. Sorry about that. All right, so let's just jump right in. And thank you, Christian, for sharing the fact that I want this to be a more open dialogue. I am going to speak around several different elements throughout my presentation. I am in presenter mode, so my colleagues, of course, from the CFAR will, be capturing any sort of chat or Q&A elements, and we can also have people raise hand to, be able to come off mute and speak on questions that you may have that comes up. So just before I jump in, thank you, Christian, for introducing me. I did work in the global and the public health realm of HIV in the federal government, majority within sub-Saharan Africa and the Caribbean when I was on the global side. And then domestically, I was a HIV prevention project officer at CDC, and I also worked in Office of Infectious Disease and HIV/AIDS policy at HHS under the chief medical officer there. So I do have a breadth of experience, but also community. Community is where I started. I started as a navigator, peer navigator in undergrad in Elon and Greensboro, North Carolina. And that's where I got my beginning within the public health realm as well as in the HIV field. So just a little bit about my background before I dive in. So, what we are going to explore today is really looking at the context and the urgency, like what's happening amongst the HIV policy challenges facing Tennessee specifically as a state. Now, I'm not going to dive too much into purpose and vision of this particular working group because I know you all, as some of the members, and Christian as the co-chair of that particular working group, will be able to dive deeper within that yourselves. But I am going to broadly make some, you know, almost instructions on what I think, or recommendations is a better way to say it, of what I think that the working group members should really be focusing on as you all build and grow and execute the work of the working group. We'll talk a brief amount around the strategic approaches to navigating policy related barriers, strengthening partnerships and community engagement, and then closing by inspiring the action and sustained collaboration of this group, the members of the CFAR writ large and generally, but also gaining the traction that you have with the community-based organizations within Tennessee and also community in general as well. All right, so we know how catastrophic things have been, specifically starting of the last year CDC funding rejection that Tennessee executed, and how this affected the HIV program budgets, how it affected limiting research and clinical service continuity in the state, but also how it impacted those that are living with HIV and getting their medications, or seeking other care and treatment needs and services, but also the preventative or prevention side of things. So we know from that how much of an impact that much money can make in just one area of a health area or healthcare concern like HIV. Now, when we think about this, we have to think about the impact, but also what do we do in response? And so we think around research and the clinical services threat. I already kind of talked about that, but we have to think that when you have ongoing research or clinical services that require like funding, channels to continue, those things being interrupted can mess up the whole care continuum for a clinic, a hospital, or a wing of a hospital if it's an ID clinic or something in that nature. So these are serious ramifications to reject that amount of funding. I know we have the Nashville Cares CEO who spoke out in various forms and mediums around the impact at the community level. And it's important to remember, when we are not getting the funding from the Fed, that goes and trickles down to every single level below. And I think that's a significant element here to talk about. but thinking around the response. I was introduced to the response that some of you all, a part of this Tennessee CFAR, made to apply for NIH funding in response to the rejection of the 9 million from CDC. And I think that has to be, recognized. It has to be vocalized, because that effort collaboratively, that's the strategic response that is needed in a concerning situation, especially how this is going to impact patients, how this is going to impact people. And so I wanted to call that out briefly. Just when we think about strategic response, funding setback always should make an urgency of like, how is our response going to be orchestrated? And I think when you think of applying for emergency funding, or gathering and meeting to figure out, like, do we need to do a call to action to legislators, or as scientists, clinicians, researchers, the staff, students, community members, regular people, how can we all come together to make a strategic response with this uncalled for action from a government entity when it comes to funding? So this particular piece I wanted to cover because it is very significant and unique to Tennessee in regards to the HIV response in your state. So I wanted to cover that and transition now into immediate impacts on research and clinical services. So we know from that instance of the rejection of the CDC funding, now we're facing an even more decrease of funding with this one big beautiful bill and the current budget from the federal government that we're looking at, that is going to impact state budgets, and what state funding is going to be looking like in the near future. So that being said, we have these three categories that I put on this slide. We're looking at research resources being reduced. So clearly, not only is the funding projection going to impact that, but what's happening at all of the HHS and the agencies under HHS, this is inclusive of NIH, SAMHSA, Center for Medicaid and Medicare Services, CMS, CDC, you name it, right? All of those agencies that fall under the umbrella of HHS are all impacted by these budget changes and cuts. So that is going to make a difference in regards to what resources are going to be provided for both research and clinical services. And we know that optimal and quality care is going to be impacted by these cuts. And so what elements or what tools, what resources strategically can be utilized to restart planning in the response to these fiscal changes, and what their physical results would of course come once things are really rendered in the coming months. That's on the way with what we're facing despite this current government shutdown. And then our HIV response, ending HIV by 2030, and those elements, the ending the HIV or ending the epidemic initiatives and that work gets slowed down, unfortunately, because if we don't have the funding sources to be able to procure commodities and to be able to provide, compensation for healthcare workers and those that are in clinics and all the staff that goes into this work, then we have a slow progression. We have to think about what are alternative methods of funding sources that we have not tapped in the past 4 decades or so to be able to help with funding the needs that we have on our hands for the response within the state of Tennessee for the HIV response. These are the sort of questions and things that have to be thought about as you think and generate policy ideas, advocacy ideas, as well as educational ideas for both resources, tools, etc., that this working group can explore and develop and implement, both within your CFAR as well as in the greater Tennessee communities. So political determinants of health, we hear this a lot when we talk about health equity. we also hear this a lot, just thinking around the kind of social determinants of health, but these political determinants of health are real, and they have great implications for the HIV community. So, for example, these political factors have really the current political environment has changed the vision and scope of public health since the beginning of the COVID-19 pandemic. And that is a reality and a fact. And anyone that's on this call or anyone that has been a public health practitioner like myself, we understand those impacts and we saw it and we felt it. And it's still trauma that we're facing and trying to overcome from those impacts. And I would say in my career, and I know I've only been doing this work for over a decade now, but those who have been in this work longer can probably look at other examples over their career, but this from 2021 to present, those 4 years have been such a large hit. And I just want to focus on that just a little bit because it's something that's very important for us to remember and recognize, especially as public health practitioners, researchers, and clinicians, and scientists, and professors or mentors in this work. This has been a very historic, I would say, 4 years for the work that we do on a daily, right? Access to care, and before I move to access to care, it is important to think about how the political factors have exacerbated change and maneuvered this new nuance around resource allocation. This is budget cuts. This is, the cost sharing from the federal government to the state government when it comes to like things like Medicaid and other social and welfare and health benefits that citizens need to survive and thrive as families, as children, as mothers, as women, etc. These are the sort of things that are literally impacted on a daily by these political determinants of health. And I wanted to emphasize that point too. Now, access to care. We have these policies that really does determine accessibility and availability of the services that we're providing, especially for communities that are we in the field of global health, we say affected or key populations and priority populations, and in the context domestically, these are just communities of folks that have likely higher incidence, or the epi showcases that there are higher rates of HIV prevalence within XYZ ABC communities, within that jurisdiction, within that community. These are the people that really are going to already have issues around access, that it's the current political determinants are going to exacerbate those issues, whether it's transportation, they can't take off work because of XYZ. All these things are going to be exacerbated in this current time. And this is really important to think about. The community support that comes when it comes to political determinants of health and the implications are very crucial too, because this is where you're like mitigating these disparities that are influenced by the political determinants. And how you're doing that is usually by bringing in the voices of those that are impacted the most. And that's from the community level. And you need those community levers, like your community-based organizations that support the work that this Tennessee CFAR is executing. You need them and the others. Maybe they're participants of service at the CBO, or maybe other CBOs that are in other cities within the state that are, impacted. These are sort of things you have to start thinking about and around, like how are you structuring the community leg of how you are outreaching and how you're educating in the work that you're planning to pursue from this CFAR perspective. I want to pause there and check in with my colleagues to see if there's any questions or comments or anything like that from anyone that's on the line right now.
No, I don't see anything in the chat yet. This is great.
Okay,
If
great.
people have anything they want to ask, pipe up, or I don't see any hands either.
Okay, great.
Yep, I think we're
Just
good.
wanted to check. Awesome. So teamwork makes the dream work, right? And this slide is more directed to your co-chair leadership of this working group, as well as members of this working group, and also the general CFAR members and those who are supporting the CFAR, because you need to be focusing now on the opportunities that you have for interdisciplinary collaboration. When I say interdisciplinary collaboration, we have academics, we have academic professional staff, we have scientists, researchers, clinicians, clinical staff, clinical trial staff, you name it, public health staff, public health practitioners, you name it. We have all of that on this call, and within the general membership of the CFAR, you have students, you have student researchers, scholars, all of these people are a part of your orbit and ecosystem, and how you utilize them and how you involve them from point A to finish is very vitally important for the working group to think about and consider, as well as the general CFAR as a whole. And so when you think about collaborating amongst these different groups within your ecosystem, you have to think about this is enhancing problem solving. The different minds at the table. It's not the, it's not that mantra of there's too many leaders and not enough folks listening. It's more so the mantra of when you bring folks in from the different levels, community, from, the academic level, maybe someone from a policy or an advocacy level, someone from the angle of health equity or public health, or even population health. That's important too in this sphere. When you bring those minds together, you're bringing more likely effective and innovative solutions to solving these complex issues. Because as we know from the past, 9 months of this year, all of these issues are complex. There is no singular issue that I can think of off the top of my head right now. Everything is complex. And so it's very important to think like you have your ecosystem, everyone's interdisciplinary and intersectional. That collaboration has to be orchestrated in a strategic fashion, and executing that is very important. So how you do that is either going to make or break the results of what you produce, whether it's advocacy tools and resources or educational tools and resources, you name it. Those are very important, the way that you orchestrate and bring that together to start the problem solving and bringing strategic solutions to the work that you all want to do. And then lastly, I have already kind of stated this a bit already, but the cross-discipline collaboration is important. You may have policy, you may have advocacy and legislative. Let me tell you, legislative is a very different skill. And advocacy from the legislative lens is a very different skill. I can tell you from experience that my co-chair in the state of Virginia in 2021, when we modernized the HIV criminalization law in the state of Virginia, it took educating and training our coalition members and ourselves so that we were ready to come in front of legislators that may or may not be educated about this work and topic, but keeping a professional demeanor in executing what we needed to do. That takes a skill set that is learned, it's not innate. So I want to just make that very clear that cross-discipline is helpful because some may already have the tools that they can then train others and so forth and vice versa. So I just wanted to put that out there as well as you're addressing some major, complex, and comprehensive policy challenges in the state of Tennessee. Okay. So building your policy literacy and advocacy skills within the CFAR network in Tennessee. This is so important. And this goes more to what the point I just was talking about around training and learning how to, do legislative advocacy. This is important because one, you have to understand just the policy process. The policy process for your state, your legislative session, when that is, how you can access, I always think of legislative information systems or legis. And they're different for every state, but usually they have some sort of universal languages. But that being said, learning those tools are important because it's important to know what in the world is being proposed as a bill every legislative session in the work that you do and that you love. So public health, HIV, sexual health, STIs, all of that stuff is important to be able to know how to go onto that system online when your legislative session begins or prior to the legislative session start so that you can actually learn what was not fully executed from the last session that may be brought back to the forefront for the new session, and then track and monitor what's coming up for the new legislative session that's coming up for your state. These are important tactics and skills that I had to be educated and trained on as well, for the work that I did within state legislative advocacy for Virginia and some other states as well. So that being said, you want to make sure that you're enhancing your members' knowledge of policy development and decision making enables effective advocacy. So the more that they know how these things work and where they can go to find them, the better your advocacy is going to be effective that you're trying to, pursue from a angle of, funding cuts and getting appropriate funds earmarked for public health needs, and specifically HIV, STI, and the other categories within that space that Tennessee focuses on. I know that could vary for different states, but I'm sure that everyone understands and gets my gist there. But it's important that we center these things and train up everyone so that we all have a kind of a unison understanding of how things work and function. And all of this is capacity building when we think of like educating others and educating ourselves in the group, through training. There could be workshop and training sessions. There's, I'm sure, plenty of advocacy or legislative advocacy groups that would love to be contacted by this particular working group, to be able to learn how to do these things. I know that's what, as an example, to showcase exactly what we did with some like-minded organizations in the state of Virginia to understand how legislative advocacy works. Like, how do I go online to find the legislative information system to be able to understand what bills and things of all that nature is on the docket, and et cetera. So it's important that, just like we do in other spaces, whether it's research or some of our work within the community-based organization ecosystem, capacity building is definitely always a good thing, especially when it comes to training. Now, leveraging your data and evidence for effective policy engagement is very critical. You need to make sure you have accurate data. And accurate data should be utilized, of course, to make compelling arguments that influence the policy decisions effectively. Now, when I say accurate data, we know that CDC, over the past several months, a lot of their data has been removed from like public-facing websites. There's been the same from a global perspective from the USAID side, where some of those folks have created like new websites that are ran by former USAID staff, and also from a CDC perspective, former CDC staff, to bring back those sort of platforms as best they can. AIDS View is a very good database. I would recommend to tap into some of that data set, because it's not necessarily government controlled. It's a lot of those data points are government procured from a local, state, as well as federal level. But it is still, an ongoing tool set. There's others like, you have Kaiser Family Foundation, and you have AMFAR, and a lot of other great entities with very good databases that are current and real-time data, that you can be able to use and access for your state. Role of evidence communication. This is where we want to make sure when you're communicating evidence that is clear, and it helps the policymakers understand complex information. So sometimes you have to think of around plain language, even when articulating data. And I know that could be difficult from a higher ed and academic, scientific and research standpoint, but sometimes it is good to also, and I say this from experience, train people up on how to communicate in plain language. It is a skill that is learned, right? And so this is also another thing that I want to pinpoint and share, because it's important, because as we go in talking medical and research and clinical jargon, at the policy level, that may not work. So just, be safe and make sure that plain language is used. And this is not just verbally communicating. These are like when you do one pagers and brochures, you do not want to be too advanced. You want to make sure that everyone can understand what complex information you're trying to explain. And then focusing on the working group, I mean, you want to make sure that y'all are prioritizing reliable evidence and sharing it to support effective policy engagement when you have a set agenda or a strategy from this working group perspective and you want to pinpoint these things in quarter 1, quarter 3, et cetera. That is when you want to make sure that you have the data, you have the evidence, you have folks ready to be able to verbally or, in a physical standpoint, one page or brochure or a flyer or something like that, or something digital. You want to make sure that you have all of those things, in a row, that all your ducks are in a row, and that you are able to, not only were you sharing that, but it's going to be digested well and understandable from a plain language context as well. So I wanted to share that to you all as well. Is there any questions or comments at this point that anybody want to share or ask at this point? I'm gonna keep the silence as a continue so we can get into discussion. All right.
Oh, actually, we do have one question.
Yes.
Which is in the chat. It says, it's from Brian Goings, and it says, when focusing on policy change, when the noticeable problem is a workforce problem, how do you suggest that data be collected? And when the community voice and stories are the only data that you have?
Yeah. When it's a workforce issue, Brian, thank you for that question. There's a couple of strategies that come to mind for me. I want to say, and I don't want to, not to ruffle feathers, but I would say the old school data collection and gathering way, boots on the ground data collection. Sometimes that method may have, like, I remember during COVID deployments when I was at CDC, a lot of that stuff was like boots on the ground, like actually physically on the ground in community, whether it was testing and when you were testing, you were doing data collection all at the same time. But we had like apps on our phone that helped with data collection and stuff. And we used some of that advanced technology and innovations, but it still was boots on the ground. And I honestly think when you have collaboration and you have partnerships with the community-based organization ecosystem, those main players, whether they're small, medium, large, or extra large, you need to be working with them to see what solutions can be done when it comes to data collection. And if it's at the, local, county levels, fine. And then when you're gathering all of those different local and county data, and that creates sort of that state epi profile, that's fine. But that is the sort of the mindset that I come in with this, when we know that the funding is not going to necessarily increase, right? Definitely not going to in the next several years. And the workforce is going to be probably staggered or reduced because we're not seeing any kind of increased budget or funding levels. So those mindsets, and this is just one example of a strategy, but it's something that comes to mind from experience during COVID, that boots on the ground and data collection and gathering that we were doing in various capacities throughout the US. That's sort of, I think, some of the suggestions I think of when it comes to what are we going to do in this new context, 2025 and through what, 29 or 28, under the current administration. And like, how can we still make sure we capture that data at the local and county levels, and then as well as a statewide, because that's what I'm only assuming this, but that's what the AIDS view and the AMFAR and that's what they're thinking of in their strategies, I'm assuming, to make sure that nothing gets missed. And I hope that helps with your question, Brian. Any other questions, John, or any other comments in the chat?
No, not right now.
Excellent. So developing rapid response mechanisms I love this topic so much because rapid response is so important. So as in political environments, they are going to change rapidly, require flexibility and agility for effective public health management, right? This is key because I want to tell you all this. The example after the 9 million rejection, and members of this CFAR, and I'm sure others that collaborated, supported, and helped applying for emergency funding from NIH or whatever particular entity John could definitely talk about this more, and I'm sure that everyone knows from the membership perspective on this front, but that is rapid response at its best, right? Thinking about what can we do to fill the void that we have just encountered because of this major issue or this major rejection or major budget or funding cut. That's a form of rapid response. The other areas around what I'm mentioning here when you're developing mechanisms towards these political shifts is you have to think about that interdisciplinary collaboration. So that's one level and one example. What are examples from the community level? What are examples from the higher education, academic, and research level? And what are examples as practitioners, as doctors, as clinicians, and researchers and scientists? And then how could we fold all of that together to make a complex rapid response strategy? That's where I'm getting at here. And I use agile response mechanisms because we have to be agile, flexible, because this is always going to be changing, almost at a daily front, right? We're seeing every day there is a new something that is coming down from the federal that is impacting us at the state and local levels and community levels, right? So having that agility is going to be very important because then you can adapt to the new challenges and you can maintain momentum in your HIV programming, your clinical research programming, et cetera. And then you want to also think rapid response is really helpful in sustaining progress. Despite all of what's happening outside of your sphere, federal level, White House, you name it, it's helping with the program continuity. That is the key. So your rapid response could be, you know, simple alerts to maybe key state legislators that you identify that are supportive of public health programming or have been supportive in HIV programming, and letting them know how this impacted a clinical trial study or how this impacted maybe a course around public health for HIV for students, whether it's undergrad, grad, or doctorate levels. All of these things are key, and you have to think about them all because if something is happening, it's going to impact something. And you think about that as you think about strategizing around what rapid response looks like from a working group perspective. Okay, I want to share a unique element of this CFAR. The modality and structure of this CFAR is a very unique one. It's one of a kind that I'm aware of from the NIH-funded CFARs around the states, around the U.S. And I've worked in several capacities in the one in the DC area when I was still living in DC. And this one, I think, where you have almost like a multi-level approach to your CFAR with multiple institutions and a lot of involvement from the community level. Others have that too, but I think having it more like signified that you have multiple institutions that collaborate across and you have like kind of an instituted level of community, that's a unique element that you want to bolster and utilize to your advantage. And this is important because the collaboration with local, state, and even national stakeholders are key, but making sure that you remember you're doing this work for the residents and citizens of Tennessee, mainly, right? That's kind of like, even though other states are important, like I'm in Georgia and from DC and Virginia, like other states are important, but you are doing this for the Tennessee residents and natives and citizens, right? That's your main like focal point. And so you want to have connections. And I say this like there may be individuals a part of your CFAR that have connections with local, state, and federal, national government stakeholders and bodies that may already have a clear alignment around HIV policy development implementation. It's important to know that. Take stake of asking the questions, maybe a questionnaire or in one of your general meetings, like having that conversation around if there is anyone who has existing relationships in those levels of government. That's one example. And you want to engage organizations and funders, both that support kind of resource sharing and are executing HIV service delivery. So, for example, majority of the CBOs nationally and globally, well, let's talk national domestic HIV response. Most CBOs receive their funding from private sector, mainly biopharmaceutical industry, right? That is changing, thankfully, gratefully. A lot of CBOs are diversifying their funding portfolios so that it's not just a singular track. And that's a really good tactic and strategy for sustaining the community-based organization. Now, academic institutions and institutions of higher learning, majority of their funding in this space comes from a federal lens, like the NIH, National Institutes of Health, R01, various other grants, you name it. That's great. But what happens when you see what has happened from February to present? What happens when you want to still execute your work, clinical trial, and other research activities when you lose your funding and you don't have a diversified funding portfolio? You have to most likely pause or conclude those studies or conclude that research or conclude a course, a program, you name it. So these are things that if it's not from an endowment or from philanthropic and private donors, one of the conversations I've had recently in the higher ed space is, why can't we see more higher ed institutions working and getting funding directly from a philanthropic or foundation funding envelope versus mainly looking at federal funding and grants and programs funding? That is something that, the conversations are being held, but where is that execution happening? And I'm sure there could be examples out there, but it's definitely not happening in a high volume, especially for HIV. Maybe other areas, maybe keeping other components of the institution afloat, but not for a public health HIV perspective. And I think that needs to change. And then lastly, here you want to maximize your impact. So unifying your efforts among your different stakeholders to increase your effectiveness, your reach of the HIV policies and services that you're trying to procure. And again, you want to engage community at all levels. This community involvement from the beginning is so vitally important. I want to make a very important point here to say lived experience from both a person living with HIV, a person that is HIV possible, and a doctor who serves HIV, those living with HIV or those possible for HIV, and a researcher that serves those same people. All of you have lived experience. It is important that you allow the voices of all those levels to come into play and strategize, plan, develop, draft, revise, and then execute and implement. It is important that all those voices are part of the process and the strategizing from the very beginning to the very end. And if you don't include them, then you're doing a disservice. So just remember that. And then your working group partnerships, who you all prioritize to partner with and get input from the community perspective, et cetera, is very important for all of any sort of HIV policy, legislative advocacy, educational initiatives that you want to produce over time. And this goes back to what I was just mentioning, that lived experiences across various levels. So as clinicians and researchers who serve the community, who serve those living with HIV, who serve those HIV possible, you also have a lived experience from a perspective from your clinician and research and scientist hat that is valuable as well in the conversations. You don't want to undervalue or devalue those with HIV or HIV possible, but I just want you to know that your voice does matter too. And we want to both amplify your voices, their voices, all of the voices that you include in your partnerships and your stakeholders so that you have a interdisciplinary and intersectional collaborative approach to the work that you're doing and executing. So my last bit before I stop here, setting shared goals for your working group is important. I know Christian and others within this working group are going to develop a great strategy alongside all of these different community and CFAR and all these other partnerships and stakeholders that I've shared in this presentation to you all, but you also want to keep guided group efforts and guided group goals that everyone is agreeing upon and everyone is coordinated upon, and that you all are agreeing to do this in a collaborative effort. And you want to keep active membership and involvement. And you want to also, one thing that I think when we join an institution like the CFAR is that kind of the development is done already. Like we've all gotten to the upper echelon of our careers and our professions, that development is done. And I want us to remember that no matter how old we are, no matter what terminal degrees we have or how many years of experience we have, development is always or should always be a continual fashion in your work. The moment that you cut that off, you're belittling and doing a disservice to yourself. So I just wanted to keep that clear as well too. And we talked about this. Define your metrics for success and ongoing assessments. You want to evaluate your effectiveness. You want to look at continuous improvement, and you want to demonstrate value. Like, is this working group a value add to the CFAR? And you want to make sure that you can showcase and exemplify that with the work that you're doing, and continuously evaluate the work that you're doing and showcase continuous improvement. And lastly here, in regards to defining your metrics, I would say using data to identify improvement areas for your initiatives. These can be, feedback, or when you have events, or when you're doing legislative advocacy or any sort of policy work, making sure that you assess those who participated through evaluation forms and things like that, and giving feedback, and having feedback in a continuous loop to enhance your programs is key always. And you want to make sure that you demonstrate measurable impact to the stakeholders. So those who are your key audience, or the ones that you want to support in the efforts that you're executing. And then make sure there's transparency and accountability within the working group and the group efforts, because if there's no transparency and accountability, then you'll lose support that you have hoped to keep. So my conclusion, really think about strategic collaboration from an interdisciplinary and an intersectional approach. Remember, it should be a shared vision and a shared action. Your strategy should be shared amongst the stakeholders and the collaborators that you include and involve, all of those different levels of lived experience that I talked about. And the main goal here is improving HIV outcomes. We all want to end this epidemic. I know I do. I wake up every day. I remember this is my first job after a year and some months that I haven't worked in HIV like full time in the past almost 13 years. So for me, it is like always weird, but I still do work outside of my essential role around HIV, both in the Georgia, Atlanta community, but also in the national and global perspectives. But this work is passion work for me. It's heart work, HEART. And it's something that I do want to see an end to this epidemic. And I think you all do too. And with that, I'll conclude and stop sharing my slides. We'll definitely make sure folks receive these slides from the CFAR members and colleagues. But I wanted to stop and open it up to Q&A, chat, discussion, and engage everyone. Thank you so much for allowing me the time, John and Christian, Heather. And yeah, let's talk. Let's discuss, and I'll stop yapping to you all. Thank you so much.
Thank you. That was absolutely fantastic. So let's open it up for questions. I'll mention we also have Dr. Tara McKay, who is the co-director as well of the new HIV and health policy scientific working group as well.
Awesome. Yeah, Tara, go ahead.
Actually, she has her hand up.
Hi.
Great. Thank you so much. This was felt like a master class for all my different roles of increasing visibility, including for this working group, but all my other roles as well for increasing visibility and impact in our work. I really loved a lot that you had to say, and I was wondering, as you were speaking about working with legislators in Virginia, if you had kind of more specific examples
Yes.
around that's like created the opportunity for the advice that you gave around how to like do capacity building for folks to try and engage more effectively with legislators. Are there moments where you were trying to undertake that work where you like realized you just weren't connecting and had to take a different strategy, or other kinds of moments where you had some realization about we need to kind of change how we're doing things here?
Absolutely, Tara. Thank you so much for that question. So, in a Virginia context, this all was done during COVID. So, it was a very, very virtual time, unfortunately. But we garnered support with like-minded organizations, and I could list those out. The Zero Project. Zero Project was founded to do the work of modernizing or repealing HIV criminalization laws, both on a national and global setting. And that organization was one of the first partner organizations we worked with. We then got connected with the Positive Women's Network, and that's a national US, the PWN or Positive Women's Network USA. And they helped from a policy and legislative and legal angle. At the time, we worked with their legal personnel that helped us understand laws and helped us understand the Virginia Infected Sexual Battery Law, which is the HIV crim law, the name of it in the state of Virginia. And then the third partner was Equality Virginia. So the Equality chapter, believe it or not, is a good linchpin to understand from an advocacy perspective. Each of the equality chapters usually have a designated lobbyist or lobbying firm that also work in the legislative capacity for the LGBTQ plus human rights efforts. And they do a lot of health elements, especially with the different attacks around the transgender communities, right? And so that was a very good trifecta of our key partners. We had other partners that I can't necessarily disclose because of their kind of disclaimer. Happy to talk offline though about those other partners. But those three partners helped us, one, learn how to do the legislative advocacy learning and training that I talked about, and then helped us get into the doors and the spaces from those that were like-minded and those that were very just against us of what we were trying to do, and that was modernize the HIV crim law. So I do want to provide those key examples. And we did face issues when it came to things because it was all virtual. It was 2020 and 2021. And unfortunately, it was like trying to pull teeth in the best rhetoric way to put it. But it was once we got them folks into that virtual Zoom or whatnot, we did execute what was needed. We got the training that was needed. We understood how to navigate the legislative information system and so forth. Great question. Hope that answers your question, but very good question.
Yes, thank you. I have like lots of connections to some of those groups already through other work, and that's a really great reminder that they're already doing this and would be really great to just pull in to help us do it better and do some of that capacity building with us.
And what I would also respond, especially the equality chapters, history with the college chapters can be good or bad. And I want to say this. We brought it in from the executive director level and said, listen, this is impacting 24,000 plus Virginians that are living with HIV. And then there's so much more that could be HIV possible that this could impact. I know you don't have a public health or HIV realm, but our equality chapter ended up creating a role, a job for HIV specifically, right? And a policy lane. And so you just never know what doors can be opened if you garner the right support and have the right conversations, despite previous or current relationships. But I wanted to add that because I know folks who have interfaced with equality chapters can have a good or bad past or current relationship. And sometimes it's like best to just come to the table fresh and have the discussion, unpack things that may have occurred, and say this is the new business we want to execute. How can you be a partner with us on this?
Thank you.
A pleasure.
If there are no other questions, I'd like to piggyback actually on my my colleagues' perspective on capacity building. Dr. Pulliam, thank you so much for all that you've provided. I kind of wanted to go back to the example of this rapid response, right? And this ever-changing environment that we're living in, this political landscape that, every day is something new. And as you said, if there's no funding, it impacts our work, right, on the front line. And so I wanted to see if you had a little bit more examples. One of the things that I remember us having a conversation about while you were preparing for this went back to sort of preparing individuals, right? So you just brought it up again about learning the process, right? But one of the other things too that you mentioned was sort of maybe having like a policy hub where people understand sort of breaking down each of these legislations, these pieces that are coming through. What does that mean for individuals, right? And spaces that we work in, live in, breathe in, pray in, etc. So I wanted to see if maybe you had more examples where you could pull in sort of that rapid response element and how it all really lends to, for me, in my perspective, it all lends to this capacity building that you brought up.
Absolutely, Christian. That there are so many good examples of creating or the creation of a policy hub at a nonprofit level, an academic institution level. I know institutions like Duke, from like a colleague and friend, Dr. Gerard Radovizman. He's done these great ideas and explored the creation of like, how can we serve as this hub for what's occurring and the impacts that are occurring to global HIV and PEPFAR and the funding and all these impacts globally. Those are the examples that I think are very key here. And the way to design this, right? When you have a policy hub, you have designated people that are really already have the honed skills to be able to dissect policy. The moment they get like a new policy document or a new legislation that comes down, dissecting that and understanding it. Now, if you don't have those people, there's other mechanisms, right? Utilize your AI. For one, it's okay to have your AI look at some legislation or new policy. And of course, you want to go back and make sure everything is looked at and reviewed and accurate. But because sometimes you may not have the bodies or the people or the expertise, but doing it that way and in having it in a kind of like a concentrated space where members can access, read a summary, ask questions to those who may be like, the POC or point of contact for the policy hub. That is the way that you can generate this. Now, other entities that I know have designated roles for this. This is usually your director of advocacy and policy, right? But this being a CFAR and a working group, and you all having jobs on top of this already, it is important that you exercise and utilize what you do have to your disposal, and then the different tools that I mentioned, like AI and other things that eventually can curate to see how a policy hub can be built out of this working group. Because then you got to think at state and at the federal level, because the federal level stuff will impact your state. So thinking about the complexities there and how to best orchestrate things to make it more efficient and effective, that's going to be your goal. But usually entities they've carved out already, or they have instituted a new role around advocacy and policy to help with that policy hub, because I was working with a national org to help build that for them, and it kind of turned into more of a public policy institute. But the hub idea was going to be generated from a Southern HIV context, and it just kind of pivoted to a different space to be able to educate folks around the public policy and legislative and advocacy work that kind of I shared in the presentation. So I hope that helps, Christian.
Yes, absolutely. Thank you.
Let's see. Do we have any other hands up or any other questions?
I'm not seeing any, but I do want to thank you all. I know we're coming to a close here, but I just want to thank you all for bringing me on board to be able to present and speak with you all. And again, I think this working group is a spectacular addition to the CFAR in Tennessee. And I definitely want to, stay in touch with you all, Tara, Christian, and John, and other members to like see how this progresses. And please lean on me, email me and things like that. I'll make sure that let me put my email in the chat for you all to be able to reach out. But again, I think that the momentum that this is starting and the way that you all can progress and grow it's going to actually speak volumes of what a CFAR really should and can be able to execute. So you all are, I think, ahead of the tide, and stay that way, because this is going to progress into something great. I just feel it.
Well, thank you. Yeah, we're this. I cannot think of a better way to launch the new scientific working group. And for everyone on the call, do stay tuned. We're in the final stages of getting everything scheduled for the launch meeting, which you'll have plenty of time to get it on your calendars. It'll be in the afternoon at 2525 West End. So stay tuned. So with that, Dr. Pulliam, I just want to thank you again for taking the time to, I'd say, come all this way, but taking the time out of your day to speak with us. This has really been phenomenal. So thank you. And I'll say that please do tune in next month. We'll be announcing our speaker shortly. This will be the same time on a Wednesday afternoon, mid-November. So thanks again, everyone who could join us today.
Thank you so much, everyone.
Thanks.
Thank you.
Bye.
Bye. Thank
Bye.
you.
Bye.